But what we're gonna do for the rest of the class is you're gonna have your IFAK on you for the remainder of the class. So if something happens anytime in this class and we say, hey, this is a drill, let's do this, then you gotta start using your kit to treat people. Really, I don't have time or cover to be able to do anything to this patient, right? Let's say this is a wall. I'm concealed, I'm not covered, he could shoot through that, but I'm concealed, he can't see me. Direct threat care. So we have a threat, active shooter happened somewhere, we're concealed carrying, we've got our medical kit, someone went down and the shooter's still around. He's over there, I can see him, right? You're trying not to cause a big commotion right now because you don't want to become the next target, but this guy's bleeding out. Let's say you don't know where the shooter is. Shooter's around the corner somewhere. So let's think, so I've got a shooter over here. If I come, let's say this guy's been shot, femoral artery, or let's say something different. Let's say he's got something near the knee. We've got an arterial bleed down here by the knee. Shooter's over there. Really, I don't have time or cover to be able to do anything to this patient, right? If I come down here, he's already in line of sight. Let's say this is a wall, okay? So he can't see anything on this side of it, right? So I'm covered or concealed? Concealed. I'm concealed. I'm not covered. He could shoot through that, but I'm concealed. He can't see me. So now I'm working from concealment. So if, let's say he's turned around, what is my best option to provide care to him? Can I come out here and provide care? No, because all it takes is for him to turn around, right? Let's get him to cover. Concealment, if possible, initially, but really we want to get to cover, right? Because what happens if I come out here and start treating this guy? Now we've got second casualty, right? Your best medicine in this case is bullets. So if there's a shooter and he's still an active threat, if I take down the shooter, now I don't have to worry about that threat anymore, and we just went from direct threat care to indirect threat care, right? But we also have two casualties now. So especially, you can come back over here, especially in a court of law, just because he was the bad guy that started this whole deal doesn't mean that we don't provide aid to him. Now, lay down with your gun. The first thing I'm going to do when I get to the casualty is I'm going to disarm him, right? One, because he's the bad guy. And if he's still with it, he may shoot me again. So we're going to disarm him. We're going to take his weapon away. Let's say Pierce is the good guy, but he's lost a lot of blood. What happens when you lose a lot of blood? You're not thinking right. Pierce is my buddy. Pierce just shot the bad guy. I'm still taking Pierce's gun away from him, okay? And I'm going to make sure that he doesn't have another gun on him. Oh, he's got an IFAK though, so I'm going to use his IFAK, right? So if it's someone you know that you know has a medical kit, or you're working in a team or something, and you know the guys with you have medical kits on them, again, this is where we're going to use their IFAK on them, but we do want to make sure we disarm them. A lot of times if you're working like police and military, they're working in teams, radio is another thing you want to take away from them. They get on the radio and start not making a bunch of sense. You're clogging airwaves. They're keying up doing things they don't need to. They may be saying things that are confusing to people listening. This guy is a concealed carry Joe, right? He's been injured. He's got his IFAK and his gun on him. If he's completely fine, he's like, it's just a little bit of pain, that's fine. Heck, keep your gun. Shoot the guy if he comes back. Like, I don't need to take his gun right now, but we do need to observe mental status. If he's pouring out blood and he's still fine, he's not going to be fine soon, okay? So he's pouring out enough blood, we may have significant blood loss. So best medicine for this phase is bullets. We have got to take out the threat. We have got to, secure the scene as much as possible. So for a concealed carry civilian, out in public, active shooter happens, your concealed carry is going to be the best thing to mitigate that situation. Let's say the guy shoots and takes off running down the mall or wherever you're at. I don't know where he is. We've got someone bleeding out. I'm going to provide care to him. I don't know if the shooter's coming back. I've got my gun in case he does, but right now we still have a patient that's bleeding out and I don't know where that shooter is. So now we're still direct threat care because I don't know where that shooter is. So we're going to put a tourniquet on and try to get him somewhere safe. So if I've got some cover we can get him to, in case that guy comes back in a minute, he's not laying out in the middle, okay? So the only care medicinally that we're going to do in this phase is tourniquets. That's all we're going to do. If he can self-apply it, better yet. Let's say this is an open alley and I'm behind some cover, I'm good cover. What's to say I can't take a tourniquet, toss it to him, he can put his own tourniquet on, and then when the coast is clear, I can take him and drag him back behind cover. Now we can do whatever we need to. We can start wound packing and doing other stuff, but we're under cover at this point. So this is where a lot of the tactics from TCCC are military settings, people are shooting at you, and you're always providing care for someone that's shot. Now we're doing some active shooter and civilian type stuff, but we're not gonna have the same tactics, not the same resources, not the same tactical training. We're not in a team of 8 guys that are all kitted the same with IFAKs and guns and everything else. So we're making do with the resources we have, so we can pull some of those tactics from their training and expertise, but just know it's nowhere near what they're doing. So that's why when we take TCCC guidelines and we throw it out there to civilians, and civilians are taking these classes, it doesn't always apply, but there's still good stuff we can glean from it. So as a concealed carry civilian, return fire, engage the shooter, if possible, to try to save more innocent lives from being lost. Once the shooter's down, remember that is a casualty as well. So at some point we have to go triage and assess him. Take his gun away from him. The moment he goes down, maybe the first time you go, you can pull his gun away from him. So if he's still halfway with it, we at least have disarmed him, okay? So we have to keep that in mind. So if this is Joe and he's a great civilian, he returned fire, shot the person, but he's losing a lot of blood, I do want to remove his weapon from him. Again, IFAK, I'm going to use his IFAK to treat him, okay? Primary thing we're doing direct threat care is we're returning fire. We're going to try to get that casualty to safety or cover if possible. If not, at least concealment so they can't see us. Only tourniquets, self-applied if possible. If not, we're going to do some of our speedy tourniquet drills, and we're going to throw a tourniquet on real fast as we're trying to move them. What about a femoral bleed in the groin? What are we doing for that? Getting them to cover. Getting them to cover. We don't have time right now. There's still someone they could be shooting. And if we get shot now, we've got more casualties, more bleeding, more chaos, right? So our primary thing we're doing is tourniquets because they're quick. They're commercial tourniquets. We're not trying to improvise right now. It's a commercial tourniquet that's prepped, ready to go. We throw it on, lock it in place. It's fast. We're not trying to wound pack and wrap and hold pressure and all that kind of stuff. Everything else takes too long in this phase. We get to the other stuff in our next indirect threat care phase. Does that make sense? So why don't you step over there for a minute? I come out here. I'm going to be putting a tourniquet on this guy, right? He's not over there right now. I'm putting a tourniquet on. I'm getting this guy taken care of. And then Kenneth shows up. Well, I can engage him, but I've still got bleeding. So at this point, this is where we can start getting really creative, and we can start putting a knee in the groin or something. And so I'm stopping bleeding while I'm engaging. I can pull him back behind cover. I can get him behind some cover somewhere by holding pressure and all that kind of stuff. But use your knee if you have to hold bleeding. Now there's kind of controversial right now about dropping a knee in the groin because a lot of times these patients may have a pelvic injury or something, especially in the military setting when this is an IED blast or something. And so there's a lot more significant damage. I put a knee in the groin, I'm messing up bones even further, more bleeding, it's just an issue. But know that you can put pressure in the groin and also in the armpit, and that can stop bleeding from those arteries going to each extremity. So you can come back over here. So just keep in mind that if you're working on them and all of a sudden the shooter presents himself, I can drop a knee, stop what I'm doing, free up my hands, use a gun to shoot back or whatever I need to, and then I can go back to my tourniquet application. Does that make sense? If you're dragging a patient, let's say he's got severe bleed to the arm, I'm dragging a patient, I can also come up here and I can grab and dig into his armpit and try to stop that bleeding on that artery as I'm dragging him now. So rather than just coming around and grabbing him, I'm literally trying to hold that bleeding to slow the bleeding while I'm dragging him to safety. So later we'll do some drills where we still have like maybe an active shooter pops up, and just know that if you're this casualty and you're awake, alert, and oriented, you're good to go, a little bit of blood loss, you put a tourniquet on and it stopped and you're still good, you may still have a gun with you. Active shooter pops up. If I'm dragging this guy, he can still be shooting, can he? So I'm dragging this guy and something happens, he can still play, he can still be shooting, even though he can't walk. We got a tourniquet on his leg, but he can still fire back. So just because they're injured doesn't mean we have to take a gun away from them. Doesn't mean they're not in the fight if something happens, okay? Well, and that's why it's just tourniquets. It's something fast. If it's something that can't be stopped with a tourniquet, there's not a whole lot we're going to be able to do. And if we go out there and we try to start wound packing and working on someone that's already lost enough blood to where we would consider them a black tag, now we're exposing a bunch of guys to gunfire and everything for someone that's already deceased. So that's why we're minimizing the amount of treatment in the care under fire or the direct threat. Best medicine is bullets, eliminate the threat. If that threat is gone, we don't have to worry about that anymore. We move on to the indirect threat care. Like, we're in the next phase. As soon as that threat is gone, move him to cover, throw him a tourniquet. If I can be behind cover and throw him a tourniquet, he can take care of himself. He's already out there. I can't help that. But if we go out there to get him, now we're exposed too, and now we could have 3, 4, 5, 6 casualties.
If you've got 2 guys on one patient, could one guy apply tourniquets and the other guy with the gun hold cover for him?
Absolutely, absolutely. And that's where, okay, let's say it's a group of us and we're all concealed carrying and we're at, I don't know, we're going bowling or whatever, and something happens and there's a guy just lighting people up and there's someone else that we need to get to and we've got cover. Absolutely, drop some cover fire. Start pulling cover fire, someone runs out and grabs them and pulls them back, and now we can start putting tourniquets and stuff on. So those are team tactics now that start moving into like tactical guns, maneuvering, cover fire, stuff that we're not really getting into in this class. But if we're talking about being, you know, top-notch concealed carry guys and we're doing shooting practice and medical care and everything else, yes, that now becomes a part of it, of us putting cover fire down to keep that guy at bay to go out and grab someone and pull them to cover to where we can treat them. That's exactly what the whole direct threat care versus indirect threat care, and why the military calls it care under fire. I'm literally taking on firepower. I'm not going to go out there and put a tourniquet on. So there's in the military setting, there may still be bullets flying, but he's behind a concrete wall now. So we can start wound packing and doing all that stuff to him. The shooter is not going to come up on him right away because we either have someone covering for him or that threat has been neutralized or whatever. Does that make sense? So the only thing we're doing initially, until we know that, or until there's no more bullets flying and that active shooter has been neutralized, tourniquet, pull them to cover, return fire, that kind of thing. Okay, so there's going to be a lot of moving, tourniquets, that kind of stuff. We're not really going deep into medicine. If he has his own IFAC, use it. If he's got a gun or radio, consider removing that if he is altered, or if it seems that he's lost enough blood or sustained head injury or something to where he gets to the point where he's altered. Sense? So we're going to do this later when we do some of our final scenarios. You're going to have all this. You're going to need to recall all this and pull weapons away from people that don't need it. Leave the weapon with the person that does. They may have to return fire to someone that pops out in front of you. So just try to keep thinking through these things as we move on throughout the class. We good? Let's move outside and go over massive hemorrhage. So let's head outside and we'll huddle around the M.